Hello, and welcome to the Society of Critical Care Medicine's iCritical Care podcast. I'm your host, Dr. Margaret Parker. Today, I will be speaking with Aaron Bansal, MD, on the article Randomized Clinical Trial of 20% Mannitol versus 3% Hypertonic Saline in Children with Raised Intracranial Pressure Due to Acute Central Nervous System Infections, published in Pediatric Critical Care Medicine. To access the full article, visit pccmjournal.org. Dr. Bansal is a professor in the Pediatric Critical Care Unit in the Department of Pediatrics at the Advanced Pediatric Center Postgraduate Institute of Medical Education and Research in Chandigarh, India. Welcome, Dr. Bansal.
Thank you. Thank you, Dr. Margaret, for having me.
You're welcome. Before we start, do you have any disclosures to report?
No, none to disclose.
Okay, thank you. So, Aaron, would you start by giving us some background for your study? What led you to do this randomized clinical trial?
Yeah. Thank you, Dr. Margaret, for having me. First of all, I would like to thank you and the SCCM for inviting me. So, coming back to your question on the what led to and what made us think about this RCT. Traditionally, we all have been using Mannitol as a osmotherapeutic agent in all children with raised ICP, whether traumatic or non-traumatic brain injuries. And gradually, we came to realize that Mannitol has got its own side effects, especially significant diuresis and hypertension, and that lead to significant rebound rise in raised ICP. So we had some data on this in pediatric patients from the traumatic brain injury children. But there were none of these was available, such data was available in non-traumatic brain injuries. Surgeons are commonly using Mannitol and they still use, I think, I don't know, maybe they have something for Mannitol and that's their preferred drug. But in our personal experience in our unit and in my own experience also, what I observed was that with the Mannitol, we saw significant drop in blood pressure over a period of time, and that led to decrease in the cerebral perfusion pressure, the brain perfusion, and then the rebound raised in ICP used to occur. Child used to go in shock, and that led to many problems. So that's when we thought that a hypertonic saline, we tried in few patients, it did work, and we had some pleasant experience with that drug over a period of time. But then we looked at the literature, we find now much evidence on this in pediatric patient in non-traumatic comas, especially in CNS infections. So then we thought about it, did some literature search, and we planned that this would be a good topic to look into. And if we can get some evidence in favor or of HTS or otherwise, it will be a good addition to the current medical literature and a good addition to the science. So that's how we came up this with the idea. And then I had a good team, and Dr. Ramesh joined me as my research fellow. So he was very keen on doing this as a part of his research because we had done some papers together on raised ICP earlier also. So that's how this seed was germinated in our thought process, and we came up with this. And we are glad that we did it because we got some very interesting data on this paper.
So tell us how you did the study.
That's a very good question. Basically, we have been using the invasive ICP monitoring in our unit since I would say year 2003-4 onwards. So we are now commonly using in invasive ICP monitoring in all the patients who present with CNS infections and raised ICP. We did one earlier study on the cerebral perfusion, again a randomized controlled trial published in Critical Care Medicine Journal in 2014 on the comparison of cerebral perfusion pressure targeted versus intracranial pressure targeted therapy in CNS infections. So we developed on that paper, and we designed this on the Mannitol versus HT hypertonic saline study on this. So what we did was, and also I would like to add one more thing in this, that CNS infections are very common in our part of the world, and in our ICU, infections predominate. Approximately 60 to 70% of our patients are loaded with infections, and out of which the CNS infections are very predominantly seen. So what we did was we basically took all the patients who presented with the clinical history of CNS infections that included either meningitis or encephalitis. They were included, which if they satisfy our inclusion criteria into the CNS infections, we included children between the age of 1 to 12-year-old, and who had features of raised ICP, clinical features of raised ICP at presentation. So all these children were randomized into either arm, means either onto the hypertonic saline arm or to the mannitol arm. We excluded some of the children, like children with malaria, which is very common in our part, dengue, and children who had already received mannitol or who had features of brain death. They were excluded at admission. So after randomization, which was a computer-generated randomization, block randomizations were done. They received either mannitol at a dose of 0.5 gram per kg over 20 minutes, and then um, after every 4 hours or longer, as and when it was required. And hypertonic saline we initially gave as a bolus of 10 ml per kg and over 20 minutes, and then an infusion of 0.5 to 1 ml per kg per hour was started, and it was hiked in a sliding scale infusion parameter was followed. And before starting this drug, and we inserted the ICP catheter in all our patients. So ICP catheter is inserted bedside by our team of fellows working in the ICU. We use the Codman Johnson and Johnson's ICP monitor. So that's an intraparenchymal ICP catheter, which is used, fiber optic catheter, which can measure the continuous change in the any changes in the ICP which is happening inside the brain. So once that was inserted, the patient was randomized into either of the arm. They were started on that particular drug. Then for the next 48 to 72 hours, we continuously monitored their baseline parameters and all the hemodynamic and ICP parameters every 2 hourly. And we continued with the osmotherapy. And then in the hypertonic saline, serum sodium was monitored every 6 hourly because of the risk of hyponatremia. And we targeted the maximum serum sodium of 155. And we also measured the serum osmolality in all these patients. Every 6 hourly was monitored. So we did not allow the osmolality to go above 360 in the hypertonic saline group. Similarly, in the mannitol group, they were receiving mannitol every 4 hourly or later, depending upon the spikes, which are ICP spikes, which are happening. And serum osmolality was monitored also every 6 hourly on these patients. And we calculated the osmolar gap also along with. Any adverse effects of hypertonic saline or mannitol related drug were monitored, like diuresis, hypertension, serum sodium, renal injury, and hemolysis or coagulopathy, and all these features were monitored. Then we, at discharge, we monitored their neurological parameter. That's their functional outcome based on the pediatric cerebral performance category scale. And this parameter or this scale, this tool was used again at the follow-up in all the survivors at 3 months. So on the basis of their functional status, they were classified as normal, mild, moderate, or severe disability. And so that's it. I think we it required a lot of monitoring and lot of interventions were there. So monitoring was both clinical and laboratory based. So I think we had collected the data very robustly, and all this was digitally recorded in all our digital softwares.
Quite an impressive effort. What were your primary and secondary outcomes?
Our main outcome was the whether how many proportion of patients had achieved the ICP, which was less than 20 millimeters of mercury during 72 hours. That's the target ICP which we had set at. And we had also measured a few secondary outcomes, which was the modified Glasgow Coma scale at 72 hours at PICU discharge, and any complications which had developed with any of the drugs which required discontinuation or withholding of osmotherapy. We also measured the ventilatory free days and the PICU stay days. Then at the end of their PICU stay, we also calculated the PICU mortality. And then functional neurological outcome status at PICU discharge was also measured in all these children. So we actually wanted to measure the mortality outcome in these cases, but then the sample size for mortality was coming too large. So that was the reason we couldn't do that.
So tell us what you found when you looked at your data.
Yeah. Uh, so it was an interesting outcome which we came out from this paper, and we were also though we had hypothesized that a hypertonic saline is better in controlling the ICP, but our results were quite significant. We screened approximately, I think exactly 109 patients, and out of which we enrolled 57 patients, 29 in the hypertonic saline arm and 28 in the mannitol group. So all the baseline we found, they were all very comparable in terms of their age, sex, and hemodynamic parameters, their ICP's value, their cerebral perfusion pressure values. They were almost similar in both the groups. So as per the primary outcome, which was the proportion of patients who achieved the target ICP less than 20, we found that in the hypertonic saline arm, there was a significant number of patients who had achieved ICP less than 20 in the first 72 hours, as high as up to 80%, compared to approximately 53 or 54% in the mannitol arm. So that was very significant, and means coming to the hazard ratio of approximately 2.63. So we also observed that the mean ICP during the first 72 hours was significantly lower, and in the hypertonic saline arm, and the mean ICP in first 72 hours in the hypertonic saline group was 14 millimeters of mercury compared to 22 millimeters of mercury in the mannitol group. And as the mean ICP was lower, so similarly, the cerebral perfusion pressure was also above our target range. And in the hypertonic saline arm, which was 65 millimeters mercury compared to 58 in the mannitol group. So, and we also compared the delta ICP changes in both the groups. So there was significant fall of ICP from the baseline to 72 hours in the hypertonic saline group. So there was a fall of approximately 14 millimeters of ICP in the hypertonic saline group compared to just 5.4 millimeters in the mannitol group. And similarly, the change in cerebral perfusion pressure, the delta CPP was also quite significantly increased in the hypertonic saline group. So all our primary outcome objectives were significant in this arm as compared to in the hypertonic saline arm as compared to the mannitol group. When we compared our secondary outcomes, we similarly found that our modified Glasgow Coma score, both at 72 hours and at PICU discharge, was significantly improved in the hypertonic saline group. And we also found that the duration of the children requiring hyperventilation was less in the hypertonic saline group than in the mannitol group. So all these results were quite significant and favoring the hypertonic saline usage in raised ICP in CNS infections. We another interesting thing which people usually see about the any procedure related complications or drug related complications. So we interestingly in our 57 patients we did not find any procedure related complications like any bleed or the displacement of the catheter or any local site infection. So no such adverse events were found in related to the procedure. And similarly, if we measured the, if we had seen the hypernatremia in the uh, hypertonic saline group versus the mannitol group, there was not much difference, a significant difference in both the arms. And also the procedure, mannitol related hypotension, um, that was quite significant. That was another interesting finding which we saw, that the hypertension in hypertonic saline arm was seen in only two patients out of all the 28 patients, compared to 16 patients in the mannitol group. So hypertension, which is a dreaded complication in any child with raised ICP, was quite significantly high in the mannitol group. So that's what we had observed, that even in the outcome wise and in the adverse parameters and complications, they were significantly lower in the hypertonic saline group.
Really interesting findings. Can you talk about the limitations of this study?
Uh, the major limitation of this study, Dr. Margaret, I think, was that this is a single center study. And we had included, though we had included a cohort of the patients manifesting the CNS infections, but then it may not be so easily extrapolated to the other centers. So I think we, to cover that, maybe a multicentric study which we can have a large sample size, and all the subgroups of infections can be covered in that, would be a very good study, and this can form a basis or a template for that to build upon that. Also, we had not measured the cerebral metabolism, like the glucose, oxygen, lactate. The brain metabolism parameters were not measured, and we had not measured the continuous autoregulation, which now we have now got few softwares available in which you can measure the autoregulation parameters also in this. So these were one of a few of those limitations. Along with, we had included all the cohort of CNS infections. We had not specified into whether bacterial infections or viral infections or any other atypical infections will behave similarly or differently in these group, because traumatic injuries, different infections, other non-traumatic comas have all different etiologies and mechanism of action in the increase in ICP. Uh, One more feature which was limiting in our study was that the dosage of mannitol. We had used a 20% mannitol, and we have used a 3% hypertonic saline. People have used 7.5% hypertonic saline, 23% saline, or people have used, we have used fixed and intermittent dosing of 20% mannitol. So various combinations are available, and they might have different effects on the outcome. But we had used this mannitol dosage, and maximum dosage we had fixed at 2 grams per kg, because we were quite concerned about its side effects, which was mainly hypertension. And even at this dosage, we think we found that significant number of patients developed hypertension with the usage of mannitol. So I think using more higher or not more, I mean say higher doses of mannitol can lead to more serious side effects. So that may not be advisable. So these are the few of our limitations, which can, I think we can beat this or tide over this limitation if we can have a large sample size and a multi-centric from different regions so that it can be extrapolated to other centers.
This study requires placing an ICP catheter via burr hole. Who does the burr hole at your institution?
Yeah, that's, I think, a very, very important question which you have raised, Dr. Margaret. Uh, at our institution, first I will answer that it's done bedside, and our own fellows put the ICP catheter, and they have now become so trained and used to that it has passing from one semester to the other, and they get trained from the seniors, and they're very comfortable. We have not found any complications related to the placement of ICP catheter at the bedside by intensivists. Having said that, I would say that it was not easy to start with. When in 2003 and 4 we got this machine in our unit and wanted to start it, we had some resistance from the neurosurgeons regarding who will put the ICP catheter, because I think that's one of the limiting factor in many other centers to when they start discussing with us that they want to use this equipment in the unit. So we convince them. It's like putting any. We discuss with them like when we are putting the chest tube in we're doing pericardiocentesis, or we're doing the ventricular tap. So if that can be done and if it's well trained, people can use it. And there is also the data available that in adults there is lot of data that non-neurosurgeons have done the burr hole and placed these catheters in the unit at the bedside, including I would say like anesthetists have done it, and in emergency department people have placed it. Then we have people placing neurointensivists have done it, and non-neurosurgeons, and all these data has been published in very good journals. So once we discuss all this in our ethics committee and we discuss with neurosurgeons, they agreed to train our fellows. So we got training from the neurosurgeons, and under their guidance we slowly developed our program. And now, after a few months of training and under their guidance, our fellows and we ourselves became very confident and started putting the catheter ourselves, doing the burr holes. And now, almost we have done more than 500 ICP placements till now, and all have been done by our fellows without any side effects. I'd like to add one more thing into this, that we published this experience to highlight that bedside placement of these catheters by pediatric intensivists is safe. So, in our own Journal of Pediatric Critical Care Medicine, we published our data in year 2015 that bedside burr hole for ICP monitoring performed by pediatric intensivists, our 10-year experience. So we published that, we shown that 265 ICP catheters were placed over a period of 10 years, and we did not find any adverse event related to that, and it has shown that it's quite useful. Other advantage that if you do it bedside and you train your fellows and yourself to do it is that you save a lot of time, because we all know how busy the neurosurgeons are. They might, when you send a call, they might be very busy or they might take time. We saw that it can delay the procedure to as much as 24 to 48 hours because of their busy schedule and limited availabilities. So if you put an early catheter, you can save a lot of time and your outcome is significantly better. That is what we had shown in our that paper also. So I think it is very, very important to highlight this issue, that with adequate training and guidance, it's a very safe procedure and can be easily performed by the intensivists.
Thank you very much. That's not the usual model, but clearly a very interesting point. So, what do you think your results mean for the practicing PICU clinician? Should we all be using hypertonic saline in children with CNS infections? What, where do you think we should go from here?
Yeah. What I would say is I would be very guarded in saying that. But what is very clear that I'll say that ICP monitoring is safe and it should be done. And it has, if done under proper monitor, if treat management is under proper ICP monitoring care, your outcome is much better. So that I think with our experience, I am pretty safely say that. Now coming back to hypertonic saline or mannitol, um, I would be err on the side, or I would bet on that hypertonic saline is safer and should be the first line drug for children with CNS infection and raised ICP. Mannitol, because of all its side effects in our previous experience also, and in our this study also, it has shown that it can be dangerous. So it should be reserved only for extreme cases like impending herniation, or you're having significant raised ICP which is not getting controlled. So maybe as a short term or an emergency measure, it can be used. Uh, and also, I would like to say that if even if your ICP, some centers may not have ICP because of the ICP monitoring, because of the expertise or because of the cost, they cannot afford. I think in our kind of country, like a resource limiting countries, it's quite a big cost. So even if you don't have it, I would say that clinically you can manage all children with encephalopathy, consider them to have ICP, and you target your mean arterial blood pressures towards more than 75th to 90th centile. And then we hope that your cerebral perfusion pressure would be maintained. So I would like to, in the end, I would like to say this, that use HT hypertonic saline. It is safe and it is better. But only thing in this which you have to do is to monitor your serum sodium regularly. Don't let your sodium go above 155, and definitely not above 160, because there is the data above or around these values is not very clear, and you may start seeing the side effects of the related to hypernatremia, which we don't want. So if you can do that, I think it's a very good drug to use.
Thank you very much, Aaron, for walking us through your study and presenting those really interesting results.
My pleasure. Thank you so much.
We have been talking today with Dr. Aaron Bansal from the Advanced Pediatric Center Postgraduate Institute of Medical Education and Research in Chandigarh, India, about the article Randomized Clinical Trial of 20% Mannitol versus 3% Hypertonic Saline in Children with Raised Intracranial Pressure Due to Acute Central Nervous System Infections, published in Pediatric Critical Care Medicine. This concludes another edition of the iCritical Care podcast. For the iCritical Care podcast, I'm Dr. Margaret Parker.
Margaret Parker, MD, MCCM, is Professor Emeritus of Pediatrics at Stony Brook University in New York. She is a former president of the Society of Critical Care Medicine. She is currently serving as Associate Editor of Critical Care Medicine and Senior Associate Editor of Pediatric Critical Care Medicine. Join or renew your membership with SCCM, the only multi-professional society dedicated exclusively to the advancement of critical care. Contact a customer service representative at 847-827-6888 or visit sccm.org/membership for more information. The iCritical Care podcast is the copyrighted material of the Society of Critical Care Medicine, and all rights are reserved. Statements of fact and opinion expressed in this podcast are those of authors and participants and do not imply an opinion or endorsement on the part of the Society of Critical Care Medicine, its officers, volunteers, or members, or that of the podcast commercial supporter.